people who had established coronary disease who'd been clinically stable for at least 6 months. They didn't have any advanced heart failure or renal disease. And in the follow-up period, we found that there was a significant reduction in the risk of heart attack, cardiovascular death, ischemic stroke, and the need for coronary stenting or bypass. We also looked at the data in more detail, and even without revascularization, the results on the harder endpoints of death, heart attack, and stroke were significant. And individually, the outcomes on myocardial infarction and the need for intervention with stents and bypass was also significantly reduced. Now, these benefits occurred early, and over the 5-year period, there was a 30% reduction in the risk of major outcomes. Furthermore, the treatment appeared safe, and I think you want to talk about safety, so I'll let you ask those questions.
Okay, the general public may have doubts about the safety universal use colchicine for secondary prevention. What is the safety outcome of the LoDoCo2 trial? Are the results of this trial strictly limited to patients?
You mean what is the significance and clinical implication?
Yep.
Yeah, well, very importantly, the results confirm that the treatment was very well tolerated. There was an early run-in period, and we found that over 90% of people could tolerate colchicine without any difficulty. And of those who did tolerate, the long-term tolerance was excellent. And that fits in with the experience of the use of colchicine in other conditions that we see. Now, there was no increased risk of cancer or new cancer, no increased risk of infection or pneumonia in particular. That signal was seen in Colcott, but not in this study. The significance of the study is quite clear. The treatment was used in patients who were already receiving aspirin and moderate or high dose statins in the vast majority. And so it can be used quite safely in that group of patients who we see in our clinics on a routine basis. Furthermore, the price of colchicine is likely to be low because it's never going to be patented for this purposes because of the way that the studies have been reported. And the drug is widely available. I think it's available throughout the world. So it will help individual patients, but there's a real chance that if it's widely adopted, it can impact significantly on the global burden of heart disease. And that's important.
Okay. The last question, what is the main mechanism of the cardiovascular benefits of the colchicine? Is it 0.5 milligrams per day a necessary dose?
Yeah, that's a good question. Yeah. When we started this study, we used 0.5 milligrams because that was the only dose available to us. Yeah. And we probably don't see any real reason to bring that down. Some people who are intolerant do tolerate the 0.25 or half strength quite well, and some of those can progress to full dose, but not all. So maybe in those who are intolerant, you could try a smaller dose. We don't think there's a lot to be gained by increasing up to 1 milligram a day because we're more worried about the potential for toxicity. So we'd much rather get the gain we can at the current dose that we have. Now, the dose we use in Australia, and I suspect in Asia and throughout Europe, is 0.5. In America, they don't make that dose. They make a 0.6. So there will be some dosing studies done, but probably most of the world will use a 0.5 milligram a day.